Christmas Eve 2023, we at the Andean Medical Mission had a call from a nurse in Nuevo Brema, which is a small village on the Rio Blanco in northern Bolivia. And she sent through a photograph of a young girl who had a blocked nasal duct for some time, and that had now become infected, and that infection had moved into the eye and into the orbit. And this young lady was in quite a bad state. Well, we were able to resolve that for her within about half an hour. We had discussed with the nurse what to do. We'd looked through the medicines that she had and found what she needed to treat that little girl. And 3 or 4 days later, the infection was pretty much gone, and the little girl was happy and out of pain. And that was a serious situation for that little girl to be in. And it was resolved very quickly by the Andean Medical Mission in conjunction with the local Bolivian nurse in the village of Nuevo Brema. Roll on exactly 1 year, Christmas Eve 2024, and a different village, but a little 5-year-old girl with a fungal keratitis. Now, fungus in the eye can be very destructive, and this little girl had a very advanced fungal infection in her eye. The local doctor, who works on her own, rang the Andean Medical Mission for advice, and we were able to start treatment for her. She didn't have very many drops, very many drugs suitable for the eyes, but she did have some fluids, and she had some povidone. And we were able to start treatment and then get medicines to her for continuing the treatment for that fungal infection. And now that little girl is doing very well indeed. Now, these might look like two random events, but they're not. These 2 phone calls that we've received, Christmas Eve 2023 and Christmas Eve 2024, are connected, and they're connected through a training program that the Andean Medical Mission run, and I want to talk about that today. Welcome to 2025 and to the Andean Medical Mission's presentation on building telemedicine services in remote locations. Well, the Andean Medical Mission first became aware of the need to manage trauma in Bolivia on our very first trip. We did an audit of the patients that turned up in Magdalena in 2012, and we realized very quickly that about 30% of the people that came to us blind were blind from trauma or from infections that have been poorly managed, situations that now were too late to be managed but could have been managed better had the local doctors and nurses had a bit more information and perhaps a few more medicines to actually work with. In 2016, we started our program for training village doctors, and we selected 100 village doctors that we thought would benefit from this sort of training. These are people who live and work very isolated, often on their own, hours and hours from any large medical facilities, and often with just a week or 2 weeks of actual training in ophthalmology. So they're not ophthalmologists, they're, if you like, year 6 medical students, a lot of them, or people from the town who've returned and taken a post as a doctor. They have very little training in eyes, and a lot of their decisions that they make are based on guesswork. And we thought that we could help to reduce blindness in Bolivia by giving them a little bit more information, giving them a number that they could ring and contact, which is 24/7. Every day of the year we're available to take calls from worried doctors and nurses about their patients. And that course has grown, and we probably get at least a call a week, sometimes a call a day, from our helpline from worried doctors who are trying to help their patients as best they can and just want some reassurance or want some advice as to how to proceed. And that's what I'm going to talk about today. So I would suggest that before you start, you research as best you can from the data that's available, what are the reasons why the patients in your villages or the area that you work are blind from trauma, and then try and address those subjects. For us, we found 10 disease areas where we thought could be managed a lot better. We also realized very quickly that most of the village hospitals have almost nothing in terms of medicines to actually treat patients with, and almost no instruments that are useful to them in removing things from people's eyes, which is a common occurrence in Bolivia, where there's very little eye protection. So insect wings and bits of sand and grit and things like that. And no way of magnifying, no way to see well. And so we focused on providing our doctors with a little bit of illumination. We gave them initially a torch, and then we moved over to the arc light system, which is a small portable magnifier with a white light. It also has a blue light, and it also has an ophthalmoscope, so you can actually see the retina with this instrument as well. And it's not terribly expensive to buy a few of those and to donate them or to loan them to village doctors. But some sort of illumination, some sort of magnification is very useful. And then some instruments if you have them. So we give out small tweezers, things like suture tires. They're quite useful, very small, and you can remove little bits of sand or insects and things like that. You can also use needles from a syringe, but that's actually easier sometimes, just to use a pair of tweezers and to lift the foreign body from the eye. But research it yourself, see what you need, and train in those areas that are most affecting your population. But there are some circumstances which I think will commonly occur wherever you're working in the world. And so some tips from us, things that we have learned over the years of doing this, are as follows. Number one, I would say spend quite a lot of time on anatomy with your doctors and nurses. It may seem like you're being a little bit disrespectful if you say, oh, you know where the cornea is, and you know what the retina is, and you know where the lens is. Very often they don't, and you will thank yourself later if you spend a little bit of time explaining the structures, explaining the sorts of problems that you can get, but base it around the anatomy of the eye. And it's very helpful later on to have done that, because then when your doctor rings you and says they have a corneal ulcer, for example, you're pretty sure that the ulcer is going to be on the cornea. And in our first few years, we had all sorts of things come through as corneal ulcers. Many of them were nowhere near the cornea. And so I think it's worth doing that. Most of these doctors, or the doctors that work in Bolivia, have literally had a week or 2 weeks of training on eyes, and that's not long. Secondly, there are things that are common that you want to address. One of them is infections. That, I think, is probably one of the biggest blinding causes in rural communities. It's the misunderstanding, misdiagnosis of infections, and then not having the appropriate medicines to work with. One of the biggest things that we have found is that yes, there are a lot of bacterial infections, and you can get hold of chloramphenicol reasonably easily. In Bolivia, most people in Bolivia have no resistance to antibiotics, so pretty much any of them are going to work. You need to have a choice for patients that are penicillin resistant or have an allergy to penicillin, so you need to have a couple of options. But generally, most infections will respond with antibiotics. But what many doctors get wrong here is they misdiagnose fungus, they misdiagnose viruses, and they misdiagnose angle closure. And a patient comes in with a very red eye and a lot of pain, and very often will walk out with an antibiotic, and it doesn't work effectively in fungus, and it'll make no difference at all, of course, if the patient is in angle closure. And that patient may come back in a week's time to be reviewed by the doctor, and now we're looking at a completely different circumstance where that patient is now blind, and perhaps the perforated ulcer, if it's a fungus for example, or an optic nerve that has gone, if the pressure was very high. And spending time on distinguishing those different situations is really important and well worth doing. Just get the concept that it isn't always an infection from a bacteria, and they don't just routinely give everyone antibiotics and hope. That they ring you and that they review the patients well, they take a good history and spend time on that. That'll make a difference, and that will help people and prevent blindness in the area that you're working. But most of the villages that we work in are really poorly equipped in terms of the medicines that are available to treat eye diseases. Most hospitals will have something useful. They'll probably have saline, they'll probably have povidone, and they may have an antibiotic. Unfortunately, it's often vancomycin, which we wouldn't probably start most patients on. And so giving your doctors the instruments which we spoke about earlier or later, depending on where I cut this video, giving the doctors some instruments, some illumination, some magnification, something to help them to diagnose. A telephone can also be very, very useful because you have a torch on the telephone, and of course you can take photographs and send those through. So all of that's really useful, but you're going to need some medicines. And the easiest way to deal with medicines, as we have identified, is to get the local ophthalmology community to donate unwanted samples to you. And I know in the UK there's a limit to how many samples doctors can get in a year, but that doesn't seem to apply in Bolivia at all. And doctors are just flooded with hundreds of samples of medicine. They're absolutely perfect for us to distribute throughout these villages. So we can make sure that every village has 2 or 3 different antibiotics that they can utilize. Every village has a steroid of some sort. So dexamethasone is the most commonly used one in Bolivia, but betamethasone is also available as a drop here commonly as well. So giving them a couple of ways of managing inflammation, a couple of ways of managing pressure. We have some very nice, they're generic drops, but combination drops of brimonidine, timolol, and dorzolamide all in one drop. We have Bolivia's version of Cosopt, which is quite a simple product to administer here as well. So we can manage pressure, we can manage inflammation, and we can manage infections. The hardest one to get hold of in Bolivia, strangely, is antifungal, and it's probably what blinds most village patients, or what blinds people in villages with an infection most of all is funguses. And we have access to voriconazole in Bolivia, but very infrequently, and often you will ask a pharmacy to supply it, and they can't get hold of it. And also dilating drops are very useful in inflammation. So if, for example, our little girl with the fungal keratitis, a dilating drop can be useful to help her with the pain, and if she has any uveitis, which is quite likely, then the dilating drops, something like tropicamide or atropine, can be very useful as well. So giving some dilating drops to doctors can be useful as well. And then lubricants. Any corneal ulcer, we try and get as much lubricants into that eye as we can. All of these medicines are free. You just get local ophthalmologists to collect them for you. You go around and pick them up, say thank you, and then we distribute them out throughout all of the villages that we go to, making sure that everything they have is in date and that they have the right balance of medicines, so that when they ring us, we help them with a diagnosis, and they know, and we give them a treatment plan, and they know immediately what to do, and they have the instruments and the medicines to actually deal with this. Telephone support is very important. Now, I give out my phone number as a WhatsApp number to all of these villages, and that's where the bulk of the calls come through. But it's very important that all of these villages have the telephone numbers for any ophthalmologists that are nearby. So where we work, northern Bolivia in the Beni, there are 5 ophthalmologists now, and 2 of them do operate. And you need, before you send a patient, so let's say you have a penetrating globe injury, you send your patient to Trinidad, they spend ages getting there, maybe 2 days to actually get there, and then they find that the ophthalmologist isn't operating that week. The 2 ophthalmologists that used to be there only operated every 14 days. They would do cataract and pterygium twice a month, and that was it. So if you turned up the day after their operating theatre was shut, because it wasn't theirs, they were renting it, then it was pointless going to Trinidad. You would have done better to have gone to La Paz or to Cochabamba or to Santa Cruz and sought help. So having a phone number for the local doctor to ring, and before they send a patient to see an ophthalmologist, make sure they're actually there and that they have the equipment to do it. If you send a child with a penetrating globe injury, you're going to need anesthesia, and you're going to need for that surgeon to have some very fine sutures and probably viscoelastic and everything that you would normally need in a cataract is you're probably going to need to have available on your tray. So do they have that? And it's the phone call that will determine that. Are they ready? Do they have an anaesthetist available? And do they have all of the equipment that they're going to need to actually be able to help? Otherwise, send the patient somewhere else. Another infection area that I should have touched on earlier and I didn't is births. During childbirth, it is very possible to pass infections from mother to child during the birth itself. And getting your local villages in the habit of washing the eyes after birth is a very useful way of reducing blindness. It's not difficult and it's pretty inexpensive. You need something to numb the pain, so we would probably find that most of our hospitals have lidocaine, and you can put a little drop in each eye, and then you can water down your povidone to 5% and put a little drop in the eye just after birth, and that will have an impact on blindness from gonorrhea or chlamydia. Finally, I would recommend that you leave some sort of paperwork with your doctors and nurses, whether it's a wall poster or a little booklet or something that they can access, maybe a document on WhatsApp as well. But we produced this is our little booklet. We have a number of photographs of what certain things look like, so they can compare what they're seeing with what is being described in this booklet. And then we have the best treatment options for each disease or each process that they're likely to encounter, and the medicines and the doses are also in here. And we also have the contact phone numbers for ourselves and for local ophthalmologists who we have identified as being good and accessible in terms of price. A lot of ophthalmologists in Santa Cruz will work for free with a patient if they know that they're very poor, if they know that they're, it's a little 5-year-old girl with a fungal infection, but the parents have got no money. There are some doctors here who are lovely, and they will do the whole treatment for that little child or that patient at no cost at all, or we could negotiate with them if there's a small cost involved to make sure that we get the patient well, and the price isn't the limiting factor. So give those phone numbers out as well, and we have that in our booklet. So that's it for today. Think about trauma, think about what you can do to reduce blindness from trauma, preventing people from going blind in the first place. It sounds to me like a pretty good idea.